Thank you for joining us today. My name is Annie Prasad, and I am the Product Marketing Manager at Springer Publishing. Today, we're presenting Articulating the Value of Nursing, a Career Imperative in Times of Chaos with Betty Rambur, Reuther Endowed Chair of Practice and Professor of Nursing at the University of Rhode Island. In addition, Betty currently serves on the Medicare Payment Advisory Commission, a nonpartisan group of policy experts who advise Congress on Medicare policies and payments. Before we begin, a quick reminder. This webinar is being recorded and will be available on demand at springerpub/videos in 5 to 7 days post-live event. If you have any questions, please type them into the Q&A box on your Zoom control panel. I'll bring them up at the end of the presentation. If you forget to ask a question, there'll be a brief survey sent at the end of the webinar, and you can include your questions there. Now, let's get started. I'll turn the presentation over to Betty.
Thank you so much. I am so honored to be here with you today. This is a truly unprecedented time. And we've said that a lot in the past, but this is pivotal. And there's so much happening economically, financially, politically. And the reason I'm so excited to talk with you is I know that nurses are really the solution, more than just part of the solution. And this is also a time when there's AI taking over positions and a tremendous strain. And yet, articulating the value of nursing is so important to your career, but also to our nation, to the people that we serve. And I'm hoping that by having this conversation today, we can help enhance the tools that you already have and help sharpen some new ones. So, the backdrop is that, as you know, healthcare is in enormous flux. We have enormous economic strain. You know well that we're the most expensive healthcare system in the world, and yet our outcomes are far behind other countries. We have shifting policies, a dizzying array of messages, and an urgent demand for clarity and efficiency. Nurses, we stand at the intersection of these forces and really have the potential to marshal and lead transformative change. And one important tool that has been underused by nurses, under recognized, is value informed nursing practice. It is a compass for both your career growth and systems improvement, benefiting patients and employers and society and you. So, thank you for the opportunity to chat with you about this. So, why are there special opportunities now? This nation is in serious trouble. You've probably figured that out listening to economic reports, et cetera. But focusing on healthcare, the challenge is that there are not enough well to carry the sick, financially as well as in caregiving. So the image I have here is to represent, for example, an insurance pool. And if you imagine the yellow, and imagine there's a fleet of yellow characters there, as the well and the red as the ill, everybody's putting money into the insurance pool, but the money is used for those who are ill, right? Paying their insurance, their healthcare use costs. So imagine this as taxpayers. We need enough people paying taxes to carry the care, the financial burden of our aging population. And here's where we start to run into some challenging situations. When Medicare started in 1965, shortly thereafter, there were almost 5 workers for each person on Medicare. Now that is no longer true. We're just going to be slightly above 2 in not too many years, and many, many more people aging into Medicare. Remember, as you know, people who are older tend to have more healthcare needs, chronic conditions, and thus use more resources. And here is the slide that just haunts me. I'll give you a few minutes to digest it, but you can see that even now, our total federal spending is beyond the revenues that we take in. We're spending more than we bring in. But if you look at 2041, at the current rates, our spending on Medicare, Medicaid, CHIPS, the Children Health Insurance Program, the ACA marketplace subsidies, Social Security, and net interest on our debt exceeds all revenue. That means that there, revenue for infrastructure, military, et cetera. So this is really a serious situation, and you hear lots of discussions of how we deal with this, and I'll talk about that more in just a minute. I want you to just ponder what this deficit means. Each person in the United States, every man, woman, and child, owes over $100,000. I have a not quite 1-year-old granddaughter, and I look at her thinking she has $100,000 of debt on her little head, and she can't even walk yet, right? And who owns us? Increasingly, it's other nations. Foreign investors are almost 25% of this debt. So this is very disconcerting. Now, how do we address this? Well, we can increase taxes or get rid of tax breaks. That does not seem in the wind at the moment. There is a push to retain the tax breaks. We can increase revenues. Would tariffs be a way to do that? That's pretty uncertain at this point. Or we can cut costs. And you've heard a lot about cutting costs and becoming more efficient. Thinking about healthcare and the deficit, Federal Chair Jerome Powell testified that Americans are getting nothing in return for what the U.S. spends on healthcare. Nothing. I mean, that's pretty astonishing. He's talking about our delivery. We're spending a lot of money and getting nothing. And again, I know you likely know these statistics, but we spend far more. Our prices are far higher for both our procedures and our medications. And most studies suggest that 20 to even 50% of healthcare is simply wasteful, unnecessary care. Here, we're not talking about fraud and abuse. We're just talking about things that we do that don't matter. Most studies land around 1/3. And if you think about the $4.5 trillion we spend each year on healthcare, 1/3 of $4.5 trillion is a lot of money. And remember, that money comes from taxes, right? Largely from taxes. So, what if we really focus on decreasing waste and low value care? And nurses really take the leadership role in this. And we'll talk about where and how that can be done. So, rather than across the board cuts, I would suggest that we instead need to carefully get rid of things that don't serve contemporary society, including low value care. And I just want you to think about low value care. Low value care is care that does not make a positive difference, but it's not benign. It can create a whole cascade of unnecessary treatments, et cetera, injuries. And there have been some studies that have found that certain populations not only receive less high value care, they receive more low value care. So we have a serious, serious problem. And part of that problem is how we pay for healthcare. And I'll talk about that in a minute. I just want to say one more thing about across the board cuts. It strikes me as similar to if there was a person who you're working with who really needs to do some serious weight reduction and there's a poundage you want them to get to, you set that as a target, and the strategy is to cut off their legs, right? Well, they get to that weight, but you create a whole host of other problems. And I'm very concerned about across the board cuts. I do think there's enormous promise in payment reform, which is moving away from fee-for-service care. Well, what's wrong with fee-for-service care? It's what we've all been marinated in, unless you've been in a PACE program or some other kind of global budget or all-inclusive care model. And in fee-for-service, each procedure, each Q-tip, each item is reimbursed separately. And that creates an enormous incentive to unbundle care and to do things that don't really matter. And we don't really have the incentive in a fee-for-service system to really think about the difference between what can be done and what should be done. And there's just a lot of momentum, especially in situations where providers have volume targets that they're supposed to meet. So fee-for-service to me is like pouring gas on fire. So I have to tell you proudly, this is my first AI generated image, but it wouldn't let me put fire on there, only water. So I think they thought I was trying to do something nefarious, but I feel a bit like a new mother having made my first AI generated image. So fee-for-service fuels the cost our nation spends on care. I want to have you focus for a minute on categories of waste. And you see here, even though there's a lot of conversation about waste, fraud, and abuse in the nation right now, I think it's really important to separate fraud and abuse, which is a relatively small proportion, although an important portion, from other areas such as overuse. You see that overuse is the largest category. For example, this is overuse of tests, overuse of antibiotics, screenings that are not indicated, um, and the list goes on and on. So we certainly have an opportunity to help diminish that. Missed preventative opportunities includes things like vaccines and the good parts of screening. Clinical inefficiencies, I bet most of you see them all the time. And how can we redesign care? Administrative waste, we have a multi-payer system, so there's a lot of swirl around things like pre-authorization and the different insurance companies and vendors. And then excessive prices. Our prices are higher than any place else in the world. And I want to talk about that specifically in just a bit as well. I'm not sure that we as nurses often think about how critical this issue of excessive prices is, but our patients certainly feel it because they have co-payments and deductibles, and those prices are then also rolled into the insurance premiums for the next year. So this is really serious. And you see how many things here we have the opportunity to really address. So there's a critical role for nurses at all levels and in all roles. And I'd like you to look at this graph, but replace the term quality with outcomes. This is important when we think about value informed practice, because of course we all want high quality care, but something could be delivered in the most high quality manner. But if it doesn't make a difference or it wasn't needed in the first place, it does not add to value. So I think we really need to think about what difference does what we're making, what we're doing make in the short term and the long term. And fee for service really doesn't incentivize us to do that. So why us? Well, we're the largest healthcare workforce, we're trusted, and we're uniquely positioned to influence the outcomes and the effectiveness of care. And this is really important right now as we think about this enormous cost crisis in the nation. We already do a lot of these things. You already do a lot of these things. We just don't always articulate that way. And we could do more, much more. And that would serve our nation, but also serve our careers, especially in the age of AI, where certain functions certainly will be replaced. Now, I know some groups have been anti AI. In my view, that's just simply unrealistic. I think we need to get, not only on the bandwagon, but help drive it. And I like to think of nurses as the value vanguard. The Nursing Code of Ethics talks about nurses being the vanguard in addressing emerging societal challenges. And we can be this value vanguard if we start to learn the language of money. And I think we've had kind of a reluctant relationship with that, right? But remember, the finances, the money is just the tools with which we get things done. So becoming fluent in that language really helps our careers, but also helps our nation. So I'm just going to give you a minute to look at this, and rather than read it to you. But in summary, value-informed practice is an emerging model that emphasizes achieving optimal patient outcomes while simultaneously considering and minimizing the cost. And so if you think about optimal patient outcomes, sometimes watchful waiting is the right choice. Sometimes no treatment or less treatment is the right choice. And it reframes nursing from just focusing on quality to an approach that includes economic stewardship, making us attentive to the outcomes on the person's whole life, but also the cost associated with that outcome. Now, you might think, boy, is that like rationing? Well, let's remember, we ration all the time. We just don't call it that. We ration by finances, by access. And by really being much more thoughtful stewards, we can actually deliver better care, appropriate care, less unnecessary care, and create a healthier nation. So this is a area in which nurses can balance this pursuit. And I want to just underscore that this idea was not related to nursing, but promoted, discussed in 1995 by thought leader physician David Eddy. And he argued that our overtreatment of the person right in front of us actually harms the people that we don't see. We don't feel it immediately because we think of them as society or as someone else, but that is the consequence of the overtreatment that we do. And it's been very, very hard to get the nation to move forward, and in part because of our predominant reimbursement model. So let's discuss short-term outcomes first. If you work in a hospital, you're very familiar with hospital value-based purchasing. The nation already tracks and rewards or punishes hospitals on many nurse-sensitive indicators, like hospital-acquired infections, falls. But I would say, are the rewards high enough so that the hospital has an incentive to really have enough nurses? Same would be true in long-term care. Are the financial incentives high enough to really ensure that that right thing is done? Remember, Florence Nightingale said that she who is in charge, remember, the role is not to do this right thing herself, but to ensure that this right thing is already done. Are nurses aware of the link between what they do and payment beyond, well, we need to do that or insurance won't cover it? And I often find a lot of resistance to nurses from nurses when I talk with them about hospital value-based purchasing. Some will say, well, that's just good care to pay attention to these metrics. But as a nation, we didn't care too much about them when they weren't linked to payment. Are nurses ever financially rewarded for good metrics, right? Do nurses benefit from the data I've seen? No, although there's a lot of pressure for nurses to ensure that those metrics are met. My dream is that there would be a nurse-owned hospital. And how would we organize ourselves, deliver that care, pay attention to the metrics? Now, you may or may not know that the issue of physician-owned hospital is back on the discussion board nationally. Physician-owned hospitals were really largely, I don't want to say prohibited, but turned away from with the Affordable Care Act. And the concern is that a physician could refer patients or admit patients to the hospital and benefit from that admission. There's now a discussion of should that be allowed and those prohibitions lifted. There has been private equity, which is investors opting in to purchase something and try to make a profit with it. Some of those have not gone well. But my dream was that we'd have a nurse-owned hospital. Wouldn't that be interesting? Because when you're admitted to a hospital, it's because you need nursing care, right? 24/7 nursing care, or you'd be an outpatient. So a nurse-owned hospital, actually, it could be all employees. We wouldn't have to limit it just to nurses, but wouldn't that be interesting? So what's the problem in the current model? There are several. Medicare, when it was enacted in 1965, prevented RNs from being reimbursed. And I've tried to track down the origin of this. And one historian said, who wouldn't go on the record, nobody was thinking about you, nurses. Another one said, oh, everybody knows it was the AMA and the AHA. I even went to the LBJ library to try to uncover this. And I don't know if you've ever been in that library, but there's just walls and walls and walls of records. So I don't know the answer to that, but we are not able to be reimbursed. And as you know, in a hospital, in a long-term care, nursing care is folded into the cost of the room, just like a maid in the hotel or like Jello. So it's really impossible to easily dissect the contribution of nursing to revenue only to costs. And this is a very serious problem. So in the current system, medical care, physician, nurse practitioners, those can bill, are revenue drivers. They drive the production of money. And nurses are a labor cost. So the financial incentive is to keep the former as high as possible in fee-for-service. You want to have as much of that billing going on, and the cost, the labor cost, as low as possible. Now, we see kind of the most dramatic example of this in long-term care and the staffing policies. Mandates were just put in place. Those may be revoked because there's this outcry of we really can't afford adequate staffing. And I always say anybody who is making any kind of policy around long-term care should spend 1 week being a worker in an understaffed facility and then another week being a resident. And I think we'd have policies that look pretty different. But the heart of the problem, the antecedent to the problem, is how things are paid for and how they're measured. And this has been called the visible problem of the invisible profession being nursing. There's a couple of other programs, and I'm sure you're familiar with these, but let me just briefly review them. The Hospital Readmission Reduction Program. Hospitals are not reimbursed if a person is readmitted within 30 days for the same condition. And hospital-acquired condition reduction, you're not reimbursed for things you caused in the first place. Now, this probably just seems like, oh, insurance, this and that. But remember, until these policies were put in place, hospitals were actually reimbursed more for conditions they caused in the first place, right? And so there wasn't the incentive for the same kind of thoughtfulness that we now have to really attend to. The Hospital Readmission Reduction Program, if I may just take a little waltz through history, people before the prospective payment system in 1983 that brought in DRGs, people would, insurance would reimburse the hospital for each day a person was in the hospital, no matter how long. And I remember as a young nursing student, we would actually take care of patients 2 days before their surgery. They'd be admitted for a workup and lab, and people would be in 7, 8, 9, 10 days. And as a 10-year-old, I was admitted for 3 days with a simple Colles fracture because there was an incentive to, there was no disincentive for long length of stays. Well, you know what happened. People were then discharged too early, not able to manage in the post-acute setting, readmitted. And for a long time, there was no penalty for that. Initially, there was just reporting of the readmissions, and there was no financial penalty. Now there's a financial penalty if the readmissions are excessive. So sometimes when I talk to nurses about discharge planning or whatever, I'm not sure they understand really what an important, really ethical obligation this is, to think about how do we make sure that we get this razor's edge just right, not having them hospitalized too long or too short. So post-acute care is an increasing portion of our healthcare industry. Now, there's similar value-based payment models in other sectors like long-term care, and I won't go into them, but hospital value-based purchasing really is a piece of value that nurses can impact with value-informed practice. So what does it take to really have value-informed nursing practice? Well, you need transformational leadership, right, that can foster understanding of the costs, the outflows. And if you ask almost anybody, what you did today cost, no one knows. And of course, it's different for different payers because they negotiate different rates. Nursing education must evolve to include economic stewardship and identifying and eliminating low value or wasteful practices. So I asked the students that I work with, what did you do today that had high value? What kind of low value or wasteful practices have you seen? And they'll say to me, how would I know, right? They learn from the current system. And as one student said to me, I'm still trying to learn how to put on my gloves without contaminating them. I can't think about that. But what if we talked about this from the beginning? Because remember, that debt is going to be on their shoulders, right? And process improvement strategies like lean should be absolute essential knowledge for nurses at all levels. I'm also concerned that we don't have enough entrepreneurship and intrapreneurship. Entrepreneurship is people starting new businesses and apps. Intrapreneurship is making changes within your organization. And here we have fundamental problems, I think, in the way we educate our students, because we're telling them from the beginning, learn how to take orders and execute those orders. And if I may just share a brief example, I met a young man who was going to school at Brown. He was a sophomore, and he was studying religion. And he decided he couldn't do what he wanted from religion, so he dropped out of college and started working at a PACE program. I'm sure his parents were a little excited about him dropping out of college to work as a orderly at a pace. And he realized there was a tremendous opportunity to use predictive analytics. He went back to Brown, partnered with an engineering student. They were at a health hackathon, which is where you put together entrepreneurial ideas. They got $1,000. Their company is now up to $27 million. And PACE programs are a global budget, all inclusive models for people who are nursing home eligible. And they take entire accountability for the cost and outcomes of the care. So they have an enormous incentive to keep people healthy. And he could see that. Sadly, when I had him talk to the students, he was trying to get nurses involved. He wanted some nurses to join the team. They felt that that wasn't nursing. So I think this idea that we've had of nursing has really bound us much too tightly. Where is our apps? Where's the innovations we're developing? So what are the barriers? Some nurses resist incorporating cost considerations into care, viewing it as contrary to patient advocacy or professional ethics. I think that's probably more true of my generation. We were taught that money should never be a consideration. And we see the problems with that because we have a totally unaffordable system. So, from my perspective, cost containment is not only an ethical, economic imperative, it's an ethical one. We can think about two things at once, right? So, why is this? The percentage of Americans who can afford and access prescription drugs and healthcare is at a new low, a 6-point decline from just 2022. Adults under 50 who could readily afford healthcare was the lowest, right? They're not eligible for Medicare, which is a publicly funded single payer. But even though Medicare is a publicly funded single payer, the affordability is also declining among those on Medicare. And if we have time, we can talk a little bit about that and why that's happening. Get this, more than half the country in this recent Gallup poll said that the care provided is simply not worth the cost, not worth the cost. So we have a lot to do. And we know that we have a lot of medical error and sometimes a dangerous healthcare system. So I like this term. The term hasn't quite caught on, but it was introduced by a gentleman probably 20, 30 years ago, ethonomics. It's the intersection of ethics and economics in public policy. And what is so interesting to me about this is that ethics and economics are different sides of the same coin. It doesn't matter how wonderful something is if you can't afford to do it, right? If there's no money to get it done. And I see one problem that we've had. This is an unpopular view, so you can tell me what you think. We always say, you need to advocate for your patients. We need to advocate for your patients. Well, we need to know the details, and then we can decide what should be advocated for. Let me just give you 2 examples. The Affordable Care Act has insurance band ratings of 1 to 3. Some people have argued that it should be 1 to 5, that the difference between the most expensive and the least expensive plan should be a factor of 5, not 3, because then it makes it more affordable for younger people. So which one is advocating for our patients? That takes some thinking through, right? Another example is site neutral billing, where people will be charged the same thing no matter where that care is delivered. I'm a big advocate of site neutral billing, so I'll just put that out there. But when we try to advocate, I think we really need to understand the details, because health policy is all about trade-offs. There are trade-offs. So what are other barriers to value-informed practice? A lot of us lack the formal education in thinking about economics, and that can make it difficult to integrate. But it's not more difficult than anything else we learn. It's a language. Remember the first time you saw an EKG, a bunch of squiggles on a piece of paper, right? How many things have we learned and learned to understand? My father, who is now deceased, but had said to me, "Are you sure people really want nurses understanding how the money works? Are you sure? Because if you don't understand how the money works, you don't have the levers." And it is not any more difficult than anything else we learn. It's just a different language. We do have some systemic issues. Healthcare systems may not always provide the necessary data, tools, or support for nurses to make informed decisions about resource use. So we need to start to demand those tools, and learn how to ask for them. I wanted to just mention a little bit about this excessive pricing piece, because the why our prices are so high could be fixed. And let's just talk a little bit about it. Healthcare markets are imperfect, and no market is perfect. Healthcare markets are more imperfect than others. And what do I mean by a perfect market? You can think about a perfect market would be like perfect homeostasis. When supply goes up, cost goes down. When demand goes up, supply may follow, etc. But we have a couple of things that really make it very difficult. First of all, buyers are shielded from the immediate cost impacts of their decision to use healthcare. And cost sharing in the form of co-payments and deductibles are supposed to give us some of that. But let me just trace this through with you. I assume none of you drove to work with the Rolls Royce today, right? That would be, too expensive, right? But we make decisions all the time based on the cost and the value. So, for example, you go to the grocery store and you look at the store brand green beans versus the fancy ones, and you see they're quite a bit cheaper. So you decide to go with the cheaper one because you can assess the cost and the value to you. Or coffee, you really love your Saturday morning coffee and the brand you like is really expensive, but you say that's worth it to me. We're going to do that. We ration our purchases all the time. I'm pining for an electric car. The $60,000 price tag has made me decide that my old Jeep is just fine. So we are shielded from the cost, but those costs roll into the premium for next year in an insurance-based commercial insurance like Blue Cross or whatever, and in the cost of Medicare and Medicaid and our taxes. So it's right there. So the cost and the transparency of the cost is really important. There's also asymmetry of information. Like I can read about cars and I can decide the pros and cons of that decision. And I can test out those green beans and it doesn't have too big of a consequence if I make the wrong decision. But in healthcare, there is what's called asymmetry information. We actually go to a provider for information. I have a headache. Do I have a brain tumor or do I need new glasses, right? We go for information. And this creates what is called supplier-induced demand. Providers of healthcare can create demand for their product. Let me give you another example of something that happened to me just this week. I was in a terrible rollerblading accident years ago, and a bunch of teeth were chipped. And the dentist said, this one's chipped. We need to fix that, but we should do these other ones too. How would I know, right? How do I know if those needed to be done? So in my textbook, I talk a lot about these principles of economics in very, I think down to earth ways, because they're actually very understandable and you live with them all the time. And it has huge implications for mergers and acquisitions, salaries nurses are paid, et cetera. But also those who set the prices can and do. And there is a classic text I just want to share with you. I was not aware of the role of the RUC. And the RUC is, let me just go to this next slide. The RUC is an AMA appointed group dominated by specialists. They have a methodology that they use for estimating the time and complexity of the procedures. And procedures tend to be overvalued even as they become routine and less time consuming. There's an undervaluing of primary care and cognitive services, right? We see that. And they, CMS, Centers for Medicare and Medicaid Services, accepts about 90% of their recommendations. So what's wrong with that? It distorts the Medicare fees, which ripples out to other payers because Medicaid and commercial insurance tend to follow. They have limited public scrutiny. I've worked in this world since probably 1990, and I only became aware of the RUC probably 2 years ago. And the AMA also owns the CPT codes. So how do these things go together? A Financial Times, a Britain outlet, I think I spelled that wrong, sorry, reported that Robert Kennedy Jr. plans to take on the RUC and stop this revolving door between government and doctors. That was in November. Chatters suggest they think they can survive it. It's a very obscure group, but I have publicly said I think there needs to be an independent group that also looks at what prices should be and then just see what the inter-rater reliability between those are. You know that primary nations with a strong healthcare system have strong primary care bases. And we know that MDs are not choosing primary care. Nurse practitioners are, but they face that same lure away from primary care to specialty care. I just want to briefly mention another area of big spending. We currently spend $20 billion on graduate medical education. Few taxpayers understand that they're financing physician education. Do taxpayers understand this? You might be interested in knowing we spend less than half a billion on nursing education. You can see what some of these economists have said, that residents bear the cost of their education, creating a positive economic outcome for hospitals. The funds are used in ways that are difficult to trace. But residents are becoming kind of unhappy, right? They used to be able to work 120 hours a week. That was decreased to 60. But residents are starting to feel unhappy, and unionization among residents is increasing. I never thought I'd see that in my day. Well, they're unhappy, but what does GME show? Well, they're in these years, over 200% increase in plastic surgery, 190 in neurosurgery, 150 in dermatology, even as primary care focused residencies such as psychiatry and family medicine languish. I think this is a serious area that we need to really focus on. The AMA has lobbied for more slots, and yet GMA remains very hospital centric, physician focused, specialty focused, with funds going disproportionately to the Northeast, including my state of Rhode Island. But you can see these discrepancies here, and the Western states have very similar situations to Montana. So these authors have suggested other options, and I really like this, like debt reduction for physicians and nurses who work in underserved areas, a wage enhancement for primary care physicians, nurses, and community workers, give the money directly to the students, or totally end it altogether and use it for other good. But if it stays, we really need to have graduate nurse education. Linda Aiken and her team have demonstrated that we can effectively prepare nurse practitioners to work in primary care at a third the cost. And some of you have probably been preceptors or have had a preceptor, but we do this without funding. It's an unfunded mandate. We have not, in my university, added a fee so that we could pay the preceptors, because that's borne on the back of the students. So all of these systems have been put in place to make it lucrative enough for hospitals, for medicine, but so much has been borne on the back of nurses. And it's time that we really start to articulate what should happen. It's time to modernize Medicare. If GME is retained, it should be expanded to nurse practitioners. I strongly believe if we really care about the elderly and nursing home quality, why don't we have residencies for adult and geriatric nurse practitioners and MDs in long-term care facilities? Remember, this money is still hospital-centric. And I know of many nurses who would be very interested and do some rotations in long-term care facilities when they're students, but they'd end up not staying after they graduate. So I think it's absolutely time to really start thinking about how life is now, not how it was in 1965. So these formulas excessively reimburse things that are now short or easy. I think about the cataract surgery I just had. I think the physician does something like 30 a day, which is sort of amazing. But we should demand deflation. If TVs had inflated at the same rate as healthcare costs from 1970 to now, a television that cost $1,500 in 1970 would be $23,000 today, right? And we know the prices of TVs have deflated. You can get one the size of a bus for a relatively inexpensive. And we have not had the kind of deflation that we should have. And we have not had the focus on care coordination and some of the other things that are so essential to people's lives and well-being. Very briefly, there has been an executive order to rapidly implement and enforce price transparency regulation. Take a look at the hospitals in your area and see if you can actually see what the prices are. The readability of these varies dramatically. To date, only 18 hospitals have been fined, and I believe the penalties are way too low. That is table dust in this world. But price transparency is only part of the story. We need value transparency. Cost is one thing, but what is it worth? And that is a key opportunity for you and for us and for our nation. So there's a lack of price transparency as well as value transparency. And the example that I gave of the coffee and the car hopefully makes it clear that functional markets depend on knowing what you're paying for and what you're receiving as a basis for better decision making. So we have a new administration. What's going to happen? Unclear for now. Less focus on hospital and specialty care could be positive for primary care. Deregulation, could that make it easier to enter practice? We still have some very archaic laws in some states where nurse practitioners cannot practice without some sort of legal connection to a physician, although they take away the staffing ratios. But let's really drive innovation. Why us? Because the nation has a great deal of trust in nurses. This isn't just overall trust. This is trust to improve the US healthcare system. Nurses are at almost twice the next closest, which is physicians. And then you see it just goes down the line with pharmaceutical companies, insurance companies, the government far below. So we are trusted. So it is time for us to really fly with both wings, our patient-centered, family-centered, wellness-centered approaches, and understanding how the money works. What gets in the way? Well, lobbying. You can see these expenditures here and understand that these expenditures are just some in the pharmaceutical area, the insurance company, the medical association, the hospital association. And here we are, American Nurses Association, less than $1 million. There are 5.2 million nurses in the United States, 4.6 of whom are practicing. If we each gave $1 towards lobbying, what a much more powerful opportunity we would have. Now, we might say, well, these organizations shouldn't have so much power, but they do. Lobbying matters. So what's next? I'm really open to thoughts, questions, suggestions, criticism, critique. I have a set of references here. And these ideas are in all of my books, but I've really expanded in the third edition. My goal is to try to make healthcare financing, economics, and policy as everyday and commonplace and as understood as everything else nurses do so well.
Thank you, Betty, for an excellent and informative presentation. We'll go ahead and take some time for questions now. Just a reminder, please be sure to type your questions into the question box in your control panel. Okay. Given everything that's happening in the policy world, if you are going to advise our listeners to pay focused attention on just one thing, what would it be?
That is a good question because it's just a dizzying array of things every day. I think there's a couple of really important opportunities. The Federal Trade Commission, which looks at monopolies and that kind of thing, that you want to have market competition. Understand, I think sometimes we as nurses feel uncomfortable with the word competition. We're talking about market competition. And there are so many barriers to nurses really being able to function the way we should, the way we can. And one of them are restrictive state practice laws. Another one is that the cost and outcomes of our work are hidden by incident to billing. Another one is that the revenue generated by our work in hospitals and long-term care, for example, is completely obscured in the room charge. So I would really pay attention to the Federal Trade Commission, and are there opportunities for us to help the help the nation really move forward.
What are the most critical skills that nurses must learn to influence policy?
Well, first of all, we all have to understand how government works. And I added to my second book a whole section on the branches of government and how they function, because I found that many of my students, and nursing is very competitive to get into, um, uh, really didn't know much about anything. They didn't know about executive orders. Executive orders have the force of law. They can be overturned by Congress. They can be overturned by the Supreme Court. But executive orders carry the force of law. And we're seeing a lot of executive orders right now. So really not understanding the branches of government was really a concern to me. And then I think really understanding health economics well enough. You don't have to be able to do the complex math. You just need to understand how that all works together. And then you can really start articulating. I see a question here. Can I answer this one? How can we get a healthcare financing a requirement in nursing education? Yes. So a couple of us, Olga Yakushiva, myself, Peter Brewhouse, really pushed that the accreditation criteria include cost and outcomes. There's a thing about quality and safety or something. Why couldn't it have been quality, safety, and cost and lace it through? I think there's a lot of challenges because often nurses don't have that background, but we can get experts who do. So I think it's so critical to understand financing, how the money is generated, but also payment, what it's used for. With a sophomore nursing student, I just completed a survey, very low response rate, of SIM programs to see what they include about low value care, assessing low value care, and was virtually nothing. And I wasn't surprised. So we have so much to do, and we're the ones who can do it. So I feel very almost frantic about it, because if we don't understand how the money works, we can't get anything done, no matter how good our other ideas are.
How can we address the concern that corporations are hiring NPs and training them to overdiagnose so that the corporation gets more money each month for the patients? What are your thoughts on the Medicare Advantage annual wellness visits used as a part of the STAR system used to list the value of the MA entities?
Yeah, thank you for that. That's a really good question. The foundational problem is the fee for service system, where you're rewarded for the more you do, right? So I am a very big proponent of all inclusive total cost of care models. And I use PACE as an example. I gave an example of PACE sooner, because then you really have accountability for the costs and outcomes over time. And I don't think we can get to a safe, effective, affordable healthcare system until we have that happening. Most of the alternative payment models, being alternative to fee for service, are built on the fee for service chassis. So that's inherent in there. And so I think that's a really, really big problem. The question about Medicare Advantage is an interesting and complicated one. And again, in this edition, I have a whole section on Medicare Advantage, because I hadn't really thought about Medicare Advantage so much until recently. Over half of Americans are on Medicare Advantage. And so traditional Medicare is fee for service, and you don't have you don't have a narrow panel. You can go wherever. But it was designed to prevent overuse. So it's only reimbursed at 80%, right? People can get a Medigap coverage, a Medicare supplement, to cover that 20%, and there's no maximum out of pocket. In Medicare Advantage, it's Medicare through a private insurance company, and they have a lot more restrictions on the panel size, pre-authorization, but they also have special benefits like gym membership and this and that. And so they market to the healthy elderly. I'm very concerned that people understand exactly what they're getting and giving up. If you go to a Medicare Advantage plan, if you want to go back to traditional Medicare, as people often do when they're ill, very ill, that is subject to, except in 4 states, there's no guarantee issue of the Medigap plan. So you might be really priced out into going out. And I've talked to colleagues of mine who have recently retired. They they feel they didn't even know they had a choice. And there's been a big kerfluffle recently where on the MedPAC group, we looked at the bonuses that brokers get for directing people to certain Medigap plans. And that has created quite a controversy. And now there's been some discussion nationally because you don't know that you're being directed to the plan. And I can tell you, working in this area, it's a dizzying array of options. So, what about the annual wellness visit? The data has not suggested that I've seen that there is a benefit, and things that don't have benefit, in my view, should not be continued. Um, there is also a lot of question writ large about the annual wellness visits overall in healthy people. And there was a very interesting article, and I'm not recalling the author, that basically said we have to unshackle ourselves from this belief that an annual visit in a healthy person is a good thing because we create whole cascades of unnecessary care. So I think starting to question everything we do, what's the cost and what's the value? I've been an outspoken proponent of looking more closely at screenings. When I was on the Green Mountain Care Board that directed oversight of all healthcare in Vermont, really, I really pushed that routine screening mammography was not a payment metric because that drives that behavior. And this is not a popular view. But there's a lot of evidence, in my view, that it's better treatments that are creating the longevity, not more screening. I have a PhD student who just is finishing up a study looking at cervical cancer screening after age 65 when it's not recommended. And it's actually quite high, and it actually seems to be high in primary care. So I think we have a lot of responsibility to start to understand what makes a difference and what doesn't. There's also the Choosing Wisely program, things you should question before doing. That's been challenging. If we had more time, I could talk a little bit more about that. But I'm in the view of there's a underused strategy to get rid of low value care. Stop paying for it, right? Stop paying for it. I can guarantee you it'll stop. Now, unfortunately, it's not always that cut and dried. But we know for example, one other state, this was not in Medicare, they were concerned with the number of C-sections and induced labors and elective induced before some week. Some of you know what week it is. I don't know. And they couldn't get it under control, and they stopped paying for it, and things turned around on a dime. So I really think what you pay for is what you get, and I do think these alternative payment programs, alternative fee for service, should be mandatory, not voluntary. If DRGs were voluntary in 1983, hospitals would still be talking about how they can't possibly move to that system and they need per diem. So we're smart people, and I think if you change the payment system, you can really get to upstream costs. You can't get to upstream costs and determinants of health, drivers of health in a fee for service system. So a long sort of rambling answer, but if anything it should be effective. You need time to test for the effectiveness, and if not, it should go.
Okay, great. Looks like we have two more questions. Best clinical practice guidelines require more testing and procedures, and there is a potential penalty if providers don't follow best practice guidelines. How can this be worked around?
Yeah, so I've done a bit of writing on the sort of the dangers of measurement. We do get measurement-driven behavior and measurement-driven harm. And one of the things that is talked about excuse me, I'm trying to share my screen here. Oh. One of the things that really is talked about is that you have to have people at the working surface modifying and continually refining the metrics. And that's why I think it's so important that nurses really grab hold of this, because we're the ones that are kind of spinning around trying to respond to these different things. So some people feel that quality measurement, outcome measurement is really come a long way. I think we're still very much in somewhat of the beginning stages because we've really looked, we tend to think about the overtreatment piece. Was there a second piece to that question that I missed?
Um, there's one more question that we'll take. Do you think it's valuable for nurses to work with lobbying and networking with insurers as a strategy?
I think it's wonderful to work with anybody as a strategy, right? And I think it's really important to really start to understand how insurance works, right? The well carry the sick financially. And insurance companies are getting a very bad rap, and I'm not trying to defend or not defend, but they're actually reflecting the cost of insurance product reflects the cost of our care. And it's true that some people have very large, salaries and all that. But the prime driver of the cost of insurance is the medical trend, how much care people are using, and the pharmaceutical trend, the cost of those. So I think if a nurse feels, I think any kind of partnership is helpful. And you may partner with a group for a while and then decide maybe you aren't aligned with their mission. But I think it could be useful. I had a colleague who worked for a while with big pharma and learned a ton, but then decided that wasn't aligned with kind of her being. But she put everything she knew as a nurse into their consideration and then learned a lot. So I think that broader partnerships are absolutely essential.
Great. It looks like we've covered all of our questions. Thank you, everyone, for spending time with us today. And thank you again to our host, Betty Rambur, for a great presentation.
Thank
If
you.
you are interested in purchasing the presenter's recently published third edition of Healthcare Finance Economics and Policy for Nurses, you will receive a 25% discount using webinar 25 at checkout on springerpub.com. The recorded session will be available on springerpub.com in 5 to 7 days. Wishing everyone a great afternoon, and we look forward to you joining future Springer Publishing webinars. Thank you, everyone.
Thank you. Bye bye.